All right. Well, I just want to start by saying thank you to Rick and to the CBRC for bringing me here today. It's a little bit of a weird situation to walk right into a conference and not meet anybody and then be the first person to speak. So, hi, I'm Nathaniel. But it's also a really great opportunity for me, as I was telling Rick, because first, as researchers, we rarely get to sort of link our research projects under a central theme, in this case, the life course, and to think about how those projects relate to one another. And second, I've always considered myself more of a social geographer who works on health-related issues, but having just begun a job as a health geographer, it feels good to kind of do a talk that anchors me squarely in that field. So that brings me to my second introductory note. So this very confused-looking set of affiliations. Well, I began as an assistant professor of health geography at University of Nottingham, technically, literally this week. But all of the research that I'll be speaking about today was conducted in Canada, mostly as a postdoctoral fellow at Dalhousie and as a postdoctoral research intern at University of Toronto, Mississauga, where I'm finishing up one of the projects now. So, sorry to say, I did actually come here from Toronto. No hate. So the recent transition also means that I haven't yet been able to locate a Nottingham PowerPoint template. So we have this very beautiful Dalhousie PowerPoint template instead. So I wanted to talk about, start by talking about life course theory in general, not just because it's the theme of this year's summit, but because I think life course, especially in terms of the social experiences that we experience at different points in life, is absolutely central in understanding some of the key issues that are experienced disproportionately by gay men, including isolation, depression, anxiety, substance use, and sexually transmitted infections, including HIV/AIDS. Now, despite what would seem like a fairly natural marriage between life course theory and gay men's health, this is actually a fairly recent sort of intervention. For most of the 20th century, our understandings of men's health and well-being were anchored in stage sequential, biologically predetermined models of human development. For example, Levinson's 1978 book, Seasons of a Man's Life. Of course, many of these models were presumptively heteronormative and centered on assumed stages of marriage and childbirth. And while we did see some integration of gay identities into human development models in the 1970s and 1980s, transitions such as coming out were still seen as predetermined in fixed stages such as identity confusion, sexual experimentation, and a one-time identity disclosure. The life course, I think, is a more flexible, reasonable alternative for looking at this because it really captures the complexity of gay men's lives, because it acknowledges biological maturation, but it sees an individual's development as influenced by the social and institutional contexts in which they are located, and the historical period that is informing those social and institutional contexts. This gives us the space to acknowledge that certain events in gay men's lives might be delayed or interrupted. One of the respondents in the first study that I'm going to talk about, I remember him mentioning, it's, for example, the process of learning to date in your 20s rather than learning to date in your teens. It allows us to think of coming out, for example, as something that happens not just all at once, but something that is an ongoing process of becoming, we might say, that might involve multiple places, multiple historical periods, and multiple disclosures throughout life. It also allows us to think of the HIV/AIDS crisis not just as a health outcome or health event, but also as a historical event that helped gay communities coalesce in the 1980s, while at the same time leaving many middle-aged men today without the partners, friends, and other social supports that they would be relying on later in the life course. Finally, the lens of social life and institutions allow us to see men's health as informed by the distinctly different levels of support and acceptance that they experience compared to heterosexual men in environments such as homes, schools, and workplaces. Now, we know intuitively that these levels of support and acceptance have been historically lower than for heterosexual men, but also that they vary across place, not just between, say, Toronto and Sault Ste. Marie, but also between an individual man's childhood home and his adult workplace, for example. Despite this, much of the work on gay men's life courses and health outcomes is presented as aspatial. That is, not necessarily contingent on the places that they live in at various points in life. While there is now a good bit of research on the gay life course, for example, on the challenges that gay men face in midlife, they aren't painted as particularly different for a gay man living in a rural area versus one who moved to Toronto early in life versus one who moved from a completely different country to Canada. At the same time, many social scientists have posited that migration is central in the lives of queer people, so it's helpful to think more about how these decisions are made and how they change the ways in which life unfolds thereafter. By the same token, in gay men's health, we often still rely on individual-based psychobehavioral models that do a good job of linking proximal and distal factors to health outcomes, but don't always talk a lot about place or context. But if we think about it, minority stress, the concept that Ilan Meyer developed in the 1990s to explain the high mental health disparities between straight men and gay men, minority stress is fundamentally rooted in place. And I'll talk more about that in a minute. So what I hope to do today is to present some case studies that show how health outcomes in gay men are fundamentally rooted in the geographies of their lives. So what I'm showing here is a figure that I've taken from an article of mine from 2009 in Health and Place, which aims to show the relationship between minority stress and place. One of the advisors from my PhD, Mark Rosenberg, would probably make fun of me here and say, well, you know, Nathaniel, everything here is related to everything else. But to dissect it quickly for you, on the right, we have some of the health outcomes in which there are high reported disparities between gay men and straight men, and on the left, the aspects of minority stress that I would describe as being rooted in place. For example, the level of structural prejudice would be higher in a jurisdiction where, either now or for a long period in history, there have been no marriage rights or no workplace anti-discrimination laws. By the same token, places where a gay community isn't particularly visible or accessible might offer fewer coping structures in terms of support from other gay men. In addition, because health services that are sensitive to sexual diversity were developed in relatively few places, usually in the aftermath of an urban AIDS epidemic, some places will not offer the kind of care that will prevent certain health issues from progressing or from developing in the first place. So given that the factors contributing to minority stress are uneven across place, it would follow then that the rates of certain outcomes would be higher, or disparities between gay and straight would be higher, but also uneven across places. At the same time, there hasn't been much research comparing disparities across places, probably because for so long the impetus was just on proving that there was a difference in outcomes between gay men and straight men, rather than these more subtle variations. So this chart, which shows the prevalence of suicide attempts among straight and LGB students in US and Canadian jurisdictions, males only for Minnesota and British Columbia, also from that article in Health and Place, represents a first stab at trying to do this. In general, we do see that the rates are lower in Massachusetts, the urban-only jurisdictions like Seattle, and in British Columbia, the only Canadian jurisdiction, and higher in jurisdictions that are more conservative or more rural like Minnesota, Vermont, and Boulder County, Colorado. Interestingly, the absolute rates and the disparities shrink in Massachusetts and Vermont between the 1990s and the 2000s, where both states became known for advancing, for example, same-sex partner rights, but not in Minnesota, where these kinds of changes didn't happen. I think that these kinds of differences prompt us to think more closely about how place and mobility affect the gay life course. So again, if we consider both the institutions that we encounter and historical context to be place-specific, then the places we inhabit across the life course, whether they be urban, rural, large, small, will affect the trajectories of our lives and most likely some of the health outcomes that we experience. In addition, we might use migration throughout the life course to deal with some of the unevenness that might delay certain events, such as coming out or being able to seek out same-sex sexual partners. So in other words, advancing a life course that one might feel to be stunted in some ways. Like Kath Weston writes about in her article, Get Thee to a Big City, gay men and lesbians moving to San Francisco, New York, and Chicago in the 1970s and 1980s were not only accessing and sometimes creating the institutions that were facilitating their own coming out and community development, but were leaving behind places that were advancing less quickly through historical time. So what I want to do today is present to you the findings of my past 3 research projects to show how some elements of gay men's life course are related to their health. The first is my dissertation research, which did not necessarily set out to focus on health specifically, but found, by doing life history interviews with 48 gay men in Ottawa and Washington, D.C., that migration was an important element of caring for oneself. The second was a postdoctoral project, and it not only focused on a specific health outcome, HIV, in an area, Nova Scotia, where it's not often studied, but since so many of my participants from the first project in Ottawa had come from the Maritimes, it was also sort of a way to go backwards and see what was happening at the other end of the migration chain. The third project kind of internationalizes the scale of this kind of research by looking at how post-migration transitions affect sexual health among gay men who are also newcomers to Canada. So as I said, the Moving Out, Moving On study involved 48 men, and this gives you an idea of where they had moved from. Now, both of the cities that I included in the study, Ottawa and Washington, D.C., are national capitals of roughly equal size, and I chose this purposely. But interestingly, Ottawa seemed to be more of a regional destination for Eastern Canada, and most of the participants were from the Maritimes, Northern Ontario, or Southwestern Ontario, which is a trend that many of the participants in the study actually corroborated. In Washington, D.C., men had moved from many different places, including many of what you might call gay homelands, like New York City, Seattle, and the Bay Area. So I think this at least tells us that moving away isn't necessarily always about escaping a place that you would consider flatly homophobic. I don't know if there would be many places. I think you'd be a little hard-pressed to characterize any place as, exclusively flatly homophobic. But it's also about starting over in social relationships, negotiating family relationships, sometimes from afar, finding community, or becoming oneself by living in a new place. So when we organize these 48 moves hierarchically, and when I say these 48 moves, I mean the most recent migration, so whatever migration it was that brought them to either Ottawa or Washington, D.C., we do see a clear trend that men tended to move up the urban hierarchy, especially early in life. After age 30, however, the trend is more mixed, with almost as men moving from somewhere larger as from somewhere smaller. And I'll get to this a bit later, why I think this might be the case. So connecting this to health, I think, is important because in fields that are closer to mine, like economics and business, we have this discourse that migration for gay men is about seeking out a particular lifestyle. And most of the research tends to sort of riff off the DINK idea, the dual income, no kids phenomenon, and the movement to cities that have more expensive housing, better nightlife, and more non-child amenities like restaurants and stores than child amenities like schools, parks, and low crime. As this quote demonstrates, however, moving out for gay men often occurs much earlier in the life course, sometimes before there's any income at all, let alone dual incomes, and it's a decision that has quite a lot of gravity, much of it related to health. So in this particular case, for Luke, who had moved to Ottawa from southwestern Ontario, it was a matter of addressing health issues ranging from anxiety to panic disorder to migraines to ulcers. And I think this next quote shows not only that the same stressors that might produce anxiety, panic, or ulcers can also produce more serious outcomes, such as suicide ideation and suicide attempts, but also that the life trajectory is affected not only by places, institutions, and history, but also by an individual's own subjectivities, not just sexuality, but also things like socioeconomic status and race. So for this participant, Randall, it was what he called the double whammy of being black and Aboriginal in 1990s Nova Scotia that made him feel as he would, not just that he would never succeed there, financially or otherwise, but that to actually contemplate coming out in the first place would have been introducing a triple whammy rather than a double whammy. This isn't meant to paint migration, though, as a panacea to the health problems produced by minority stress. To borrow a phrase introduced by Doug Bruce and Gary Harper, incidentally, about a year after this research was completed, I realized that many of the participants had found themselves, quote unquote, operating without a safety net after moving to larger cities, entering gay communities, having few social contacts, and all of this coinciding sometimes along with the pressures and the transitions of coming out itself. So Joseph here talked about finally getting the courage to move to DC from northern Florida in his late 20s and to go through, to begin the process of coming out in DC, but experienced a lot of disappointment after expecting, I remember him calling it coming out to be like a big hug and getting a pat on the back instead. And then, to have these emotions result not only in extreme dieting, in an effort to fit into the community, but also higher sexual risk-taking. As he says, just trying to fit in, you may not use protection because you don't want to be rejected. As men move through the life course, health and well-being are still concerns, but they don't necessarily influence locational decision-making in the same way. So as opposed to that first graphic that I showed you, which represented where men had moved from, this one represented where they planned to go next. And yes, younger men still plan to move to an even larger city, one larger than Ottawa or Washington, D.C. But what you don't see immediately by looking at this, but if you look at the note at the bottom, it's that most men over 40 were not planning to move at all. And I think this reflects a difference in needs at different points in the life course. So Adrian's quote here at the top reflects not only the clear need to move when it's in conjunction with coming out, and sometimes moving from a more rural area, but also that in the past, gay liberation and AIDS movements were very clear points of entry into urban gay communities. But once beyond coming out in the initial phase of community building, as Robert Kurtzner has observed, the social and existential meaning of a gay identity become less clear. So interestingly, what many men in their 30s, 40s, and 50s talked about was the challenge of building professional lives and community identities when they might not fit into a more heteronormative framework of workplace sports leagues, scout troops, and PTA meetings. So for Adam here, moving to DC was about moving to a place where he felt sure that his career as a professional in the federal government would advance because he felt that the civil service non-discrimination policies were more likely to be carried out in the U.S. federal capital rather than in Ohio. For others, it was about moving to a city where they knew that they could, for example, be a volunteer coach for a youth softball team and not have parents sort of looking at them sideways. So I think what this also tells you is that migration, again, is not about the pursuit of a lifestyle, but also about the pursuit of community and economic security, and that as men age, as one participant had said, not having to build that all over again. So moving on to the next case study, armed with what I had learned from my dissertation research, I set out to look more purposely at the links between place migration and sexual health for gay men. And as I said, I wanted to look specifically at how being in a non-metropolitan area might influence both more individual sexual risk behaviors and the broader structures and services tasked with prevention in an area that has always been seen, and sometimes actually seen itself, as somewhat outside of the HIV epidemic in Canada. And while there is research on the challenges for people living with HIV/AIDS in rural areas, I believe that this was one of the first studies that actually looked at the impact of rurality and being outside of a metropolitan area on risk and prevention. So again, life course figures prominently here, both because of the individual messages about their sexuality that men receive earlier in life from families, but also the more general cues that they take from institutions, government institutions, social institutions, and otherwise, in a place like Nova Scotia. And Nova Scotia is interesting because in terms of larger scale rights, for example, same-sex marriage and adoption, the province is actually, I would consider it somewhat progressive. It usually seems to be the one that kind of rings in fourth after Ontario, BC, and Quebec. But then, at a more local scale, its history is fraught with events that indicate a lack of acceptance for gay identities. This was evident in the termination of Eric Smith, a gay HIV-positive teacher in Shelburne County, Nova Scotia, and Lindsay Willow, who was temporarily fired. Lindsay Willow was another teacher who was temporarily fired because she was believed to be a lesbian and seen in a locker room with a female student. And this was in 2006. Interestingly, in 2006, many Nova Scotia public schools also banned the provincially issued sex book, which had short sections on STIs and on LGBT identities, which were considered too controversial by some school districts. A year later, the city of Truro refused to fly a pride flag. And if we compare this to, for example, the Diane Haskett refusal to issue a pride declaration in London in the 1990s, this is more than 10 years later. And up to 2012, many schools in Nova Scotia were prohibiting the formation of gay-straight alliances. And a policy was finally created to stop this by the current Minister of Education, Ramona Jennings. So you can also see this today still in terms of the overall investment in HIV prevention in Nova Scotia. So, for example, while Ontario and BC both have over 50 rapid point-of-care HIV testing sites, which have been shown to increase the uptake of testing, the diffusion of information, and the uptake of counseling, Nova Scotia and actually Atlantic Canada in general have 0 sites. So how does growing up in this kind of environment affect how gay men manage HIV risk? So the first respondent here talks about feeling sexually repressed for most of his life, and then getting to age 30 and finding that he had no sexual confidence, and then in a rush to remedy what he had gone through earlier in life, went through a period with a much higher frequency of intercourse, sometimes unprotected, as he had told me, and was thankful to come out of that eventually. An HIV nurse in Halifax commented that the culture of silence and sometimes misinformation around sex in Nova Scotia, and particularly gay sex, resulted in a different risk context compared with places where the discussion might be much more open. Some of the men also commented that perceiving Nova Scotia to be a low prevalence province, I think with 750 recorded HIV positive cases in its history and 361 cases of AIDS, made them more comfortable with some risk taking. Of course, these figures don't account for people who get tested outside of Nova Scotia, which I think actually is quite frequent given the infrastructural gaps. And the idea of a low prevalence place doesn't really acknowledge the fact that many sexual encounters might be mobile ones that occur outside of the province. So again, mobility figured into this project prominently, both inside the province and outside of the province. So this first quote from a youth outreach worker in Halifax talks about sort of a more routine mobility between outlying areas and Halifax for men who might be closeted. This was also confirmed by some online outreach being done at the AIDS Coalition of Nova Scotia, which found that about half of the questions that the counselor was receiving online were originating from profiles located in outlying counters like Colchester County and Pictou County, and usually indicated willingness to travel or indicated that they were going to be temporarily in Halifax and were looking for sex. There was also a pattern, however, of leaving and returning Halifax among, and central Nova Scotia and generally among men in their 20s, who, and this is ongoing, who might move to higher prevalence places like Toronto and Vancouver. And for these men, we might consider the so-called safety net to be even more absent, given that they've grown up in an environment not just perhaps where they weren't accepted, but also where HIV isn't perceived as a huge risk and where, compared to, say, BC, sexual health education programming is much less developed. And this has also had sort of an effect on the tenor of the gay community at large in Halifax. One quote here talks about men's experiences early in life, even among men who are out, and how this still creates a reluctance to discuss sexuality or the health risks associated with being gay and being sexually active. The second quote talks about the unwillingness to acknowledge HIV because to even discuss it would cast you as irresponsible, non-normative, and worthy of exclusion from the gay community. So in these first two studies, we've given priority first to mobility and then to the context of place. In the third case study, I want to add the element of time to the analysis. So this third project was undertaken as a national research intern with CIHR's Population Health Intervention Research Network. And the goal was to really look at how the international migration experience influences sexual health among gay men. In North America and the United Kingdom, there has been great work on sexual health among ethnic minority men, in the US especially Latinos and Asians. So for example, the impact of double discrimination on risk-taking. But this work tends to place culture and cultural affiliation as the focus of the analysis, rather than what does the process of relocation itself have to do with risk. So in general, there's two schools of thought on this topic. One, which is sort of in line with the idea of a healthy immigrant effect, if any of you are familiar with it. For those of you who are, it's that behavior becomes riskier or more unhealthy as newcomers sort of converge downward to the cultural elements of the host society, Canada, and in the case of gay, bisexual, or queer newcomers, converge to the cultural elements or behaviors of the gay community within that host society. And usually this is discussed in terms of using drugs and using other substances. So I wanted to examine this idea using both a systematic review of these ethnic minority studies, many of which are also immigrant studies, but just don't necessarily call them that, and ask, essentially, when is it, post-migration, that risk is highest, and why might this be the case? So interestingly, there are relatively few studies that actually compare risk factors in gay and bisexual immigrant men and compare them to a heterosexual referent group. But those that do, and most of these are from Europe rather than from North America, show higher rates of unprotected anal intercourse among the immigrant population, even though they also show higher rates of protective factors like getting tested. And they're sort of mixed on drug use, which is, as I said, what has been typically been associated with acculturating to a gay community among new immigrants. So by doing a systematic review of these ethnic minority studies and looking at both, number one, the degree to which the sample is comprised of immigrants rather than second-generation participants, and two, the mean length of time that the immigrant portion of the sample had been in the new host country, whether that be the US or Canada, or the United Kingdom, or Spain. I think there's one from Spain as well. I was hoping to see some kind of pattern in risk behavior. So to some extent, this review of the use of 3 different drugs, 6-month prevalence, sort of confirms this acculturation hypothesis. So in the samples that were more second generation and had been in the country relatively longer, drug use rates were higher, especially for marijuana and for ecstasy. However, if we look at the prevalence rates of unprotected anal intercourse, again, it's not the exact same set of studies. Some of them are, there's some overlap. But we see that rates are just as high, if not higher, in the samples that are 100% new immigrants. And particularly interesting is the case for the one rural study among this group of studies, a Latino study in rural North Carolina, where the rate of unprotected anal intercourse is actually the highest. So this in some ways debunks the idea that higher risk would be associated with the behaviors that are quote unquote, endemic to an urban gay community. And the second part of the study, the interviews, confirm this to some extent. So the first 2 quotes indicating that yes, in fact, among the newest immigrants, there may not be that much interaction with the gay community, not only due to sometimes being closeted within their own cultural community, or from feeling excluded in the gay community, but also because just logistically speaking, they may not have the money to participate in that sort of scene or environment, and that the priority is really on finding work, getting settled, and getting established. At the same time, This doesn't mean that they're not having sex, and in fact, it might be a form of release from the stressors of relocation, settlement, and integration. It just might not be sought out at a bar or a club or other, popular gay community venue, and it's not necessarily sought out under the influence of drugs or other substances. Yet the higher rates of unprotected sex among relatively recently arrived immigrants seem to also have something to do with the individual's experience and with the structure of gay communities within cities. So first, new immigrants might have experiences of abuse or trauma from living in places earlier in life that were hostile to their sexual identity, and therefore might not feel that speaking up for themselves is a valid thing to do. There might also be language barriers, there may also be unfamiliar risk contexts, and there's also something to be said for the experiences of racialized men in gay communities, a sense that they're not entitled to negotiate safer sex, especially with a white partner. So I think that these results show that often the higher risk we perceive in ethnic minority men is not something that necessarily amplifies over time, but is perhaps actually worst when first relocating from another country. So although these case studies are disparate in some ways, I think that they show us that even in the quote-unquote post-gay marriage era, at least in Canada, gay men's health continues to be affected by geographies of rights, social inclusion, and service provision. And I think it's important to think about the effects of mobility and time in a gay man's life course. For example, we can't necessarily think of a Nova Scotian as living in a low prevalence or low risk area because often the place where first sexual encounters are negotiated is elsewhere, outside of Nova Scotia. Also, we have to acknowledge that while some of the worst institutional homophobia might be behind us, events like the Eric Smith case in Nova Scotia, or again, as I know from working on the HIM project in London, the Diane Haskett Pride Declaration refusal in London, Ontario, still tend to weigh very heavily on the resilience of gay communities across Canada. Second, we see mobility as emerging as a personal care strategy that has the potential to, on one hand, correct interruptions and delays in the life course, but one that can also add stress and upheaval to the life course at particular points in time. I think that clear points of entry into a gay community and the accessibility of a gay community are really important to making migration work as sort of a corrective behavior. But as we saw in the first case study, these points of entry into gay communities might be less clear than they once were, and this is something that Terry alluded to in his talk at the beginning. I think that in line with life course theory, the connection between gay community and gay men's health is at a bit of a crossroads right now. On one hand, we see the sort of celebratory narrative that over time our rights have been won, and things like gay villages are just a relic of the past. And while this might be very true, for a very specific set of metropolitan, privileged, and usually white men, we also need to think about how community and care are accessed among, for example, the kid from southwestern Ontario who was kicked out of his house and shows up on a bus in Ottawa, or the new immigrant from the Dominican Republic or the Philippines who might not know what being gay means in a North American context and how to negotiate that. As sort of a second media representation of the gay life course, the It Gets Better project, I think, is also potentially really problematic. The message is not only just wait it out until you get older, but also that you can make it better for yourself by moving to a city, traveling, and fitting into a normative lifestyle, which, again, only a certain segment of the population is privileged enough to do. So this not only discounts the still very real unevenness of young gay men's experiences, even in Canada, but also places the burden of care on the individual rather than health systems and infrastructures. A bright note, I think, is something that has happened in Ottawa in the past couple of years. If you remember, Ottawa was one of the sites of the first case study, where they've actually designated a gay village for the first time. Incidentally, in the same year, where the Grid magazine article in Toronto that you saw 2 slides prior was declaring the gay village to be over. I think that this reflects the experience of a city where in the midst of, for example, RCMP civil service expulsions in the 50s, 60s, and 70s, gay identities have remained fairly invisible for a long time. And there's now a desire to correct that. I also think it represents perhaps a new kind of gay village, one that might be more common in smaller cities like Ottawa, that is really acknowledging the need for a point of entry into gay community for gay men from elsewhere. Within the village, there is a gay positive housing co-op, Gay Zone, which is one of the premier gay men's HIV testing promotion programs in Canada, and also a set of about a dozen rainbow, very hard fought, by the way, rainbow village street signs where in an area where gay visibilities had long been suppressed. So I think by looking at cases like Ottawa and challenging narratives that it now only gets better by moving somewhere or sort of assimilating into the fold, we have a better shot at promoting health and well-being for diverse groups of men across the life course. Thank you.